So once you have the suspicion and you want to move to testing, the blood-based testing includes peripheral blood smear, red cell indices such as mean corpuscular volume and mean corpuscular hemoglobin, serum ferritin, serum iron to transferrin ratio, which is iron saturation, and then bone marrow iron stain, looking for Prussian blue staining in very, very small amount of patients. You can also see increase in serum hepcidin. However, this is not clinically used and obviously not very easily accessible, but more from a research perspective as well as academic interest. It correlates with iron stores more precisely than ferritin. There's also soluble transferrin receptors, which are intracellular importers of iron, and their expression and release go up in iron deficiency anemia into the circulation. So these are some of the specific findings you see on when you send blood work, CBC. You see increased red cell distribution width. There's also reduction in mean corpuscular volume, less than 80, which is a classical traditional thing we learn in medical school. As well as on the blood smear, you see microcytosis and then hypochromasia, which is widening of the central pallor, accounting for more than 1/3 of the total RBC diameter, as seen in this figure on the right lower corner, where there's widening of the central pallor in that. It is important to remember reticulocyte count is not increased, as contrary to some of the absolute iron deficiencies, such as bleeding, where there is increase in reticulocyte counts. Further details in tests, there's a reduction in serum ferritin. There's a reduction in iron saturation, which is specifically less than 20%, and a reduction in total serum iron as well. There is an increase in total iron binding capacity, which is the maximum amount of iron needed to saturate plasma or serum transferrin. Based on these and recent clinical trials, the accepted definition at the current time is that functional iron deficiency in heart failure is reflected by a reduction in ferritin levels of less than 100 micrograms per liter, or if they are between 100 to 300 micrograms per liter, then using a transferrin saturation of less than 20%, which is reflective of iron deficiency in states in heart failure population. You can use a Gonzoni equation to calculate a total iron deficit in patients who are confirmed to have iron deficiency. This cartoon just again reflects some of the changes which are happening in iron deficiency anemia, such as high soluble transferrin in the circulation, low serum iron, as well as low hemoglobin and anemia. It's important to differentiate between iron deficiency anemia and anemia of chronic disease, and this slide reflects some of the changes. While in iron deficiency anemia, the ferritin is reduced, in anemia of chronic disease, there is increase in ferritin levels. Serum iron may be reduced in both of them. However, bone marrow iron is reduced in iron deficiency anemia, whereas in anemia of chronic disease, there may not be any change. A log of or a ratio of soluble transferrin receptors versus ferritin may be increased in iron deficiency, especially more than 2. And if it's less than 1, it would be from anemia of chronic disease. Now that you have diagnosed iron deficiency anemia, and you may choose to replete iron stores, it is important to recognize what are the timelines which the body responds to in terms of repletion of iron stores. And the peak reticulocyte count changes between 7 to 10 days. Increase, you can see an increase in hemoglobin and hematocrit up to between 14 to 21 days. It almost takes 2 months for improvement in hemoglobin and hematocrit. And the normal iron stores take up to 4 to 5 months to get fully repleted. It is important to remember there are no gold standards for recommended right now for monitoring. Whatever we have, we utilize are extrapolated from some of the clinical trials, and especially the recent ones. And however, it is reasonable to look for ferritin stores as well as saturation at 3 months. And then it's also reasonable to look for ferritin and transferrin saturation if there's a change in clinical picture in a chronic stable heart failure patient, or there's a reduction in hemoglobin, or routinely checking 1 to 2 times a year. This I would conclude by saying that iron deficiency is common in heart failure. It's multifactorial, as we have seen, and is strongly influenced by hepcidin, which is a acute phase reaction in response to inflammatory states, iron availability, and then erythropoietin response. And then iron deficiency anemia is detected by lab testing and inferred by response to iron depletion. And it's important to recognize the difference between functional and absolute iron deficiency to correctly diagnose iron deficiency in heart failure. And it's also important to utilize commonly accepted definition as used in some of the contemporary clinical trials to make a correct diagnosis and treat your patient accordingly.